At any time during your flight attendant career, you may be faced with an in-flight emergency. The most common in-flight emergencies that flight attendants encounter are illnesses and injuries. These can range from a life-threatening situation to a minor incident. It is important that your response be prompt and efficient while showing concern for the person's well-being. The First Care Plan allows you to control the situation until medical assistance is available. The following incidents are based on actual in-flight emergencies.
Okay, 1A is on your left-hand side up there by the window in the first row. Have a nice flight.
Thank you.
Hi, how are you today?
Good, thank you.
Good. Can I hang up your jacket?
No, not right now, thank you.
May I offer you a welcome beverage?
No, not now. Maybe a little while.
If you'd like anything, just let me know.
Thanks a lot. Thank you.
Mia, are you okay? Can I get you anything?
I ordered a special diabetic meal. Would you check and see if it's on board this time?
Yes, of course. I'll check right away. What's your name? What's the last name, please? Walsh. Are you sure I can't get you anything?
Nothing. Just check on the meal.
Okay, Miss Walsh. Paula, I need you to check on a diabetic meal for customer Walsh, please.
Okay.
Thank you.
I'll be right back.
Thank you. I'm going to get you some orange juice. I'll be right back. Ma'am, here. I brought you some orange juice. Okay.
Thank you.
Okay. Okay. You just hold on to that, okay? I'll be back to check on you in just a few minutes.
Thank you.
Okay. How you doing?
Much better, thank you.
Good.
You know, I'm diabetic, and I've been in such a rush trying to catch this flight, and I didn't realize I kind of didn't eat right, and it just had this effect on me. But I feel a lot better.
Oh, gosh, I'm so glad.
It just came on so sudden.
Okay, well, if you need anything else, you let us know. I did check on your meal, and we do have it, and we'll be serving to right as soon as we take off.
Great, thanks a lot.
Anything else, you let us know.
Okay, thank you.
Thank you.
Okay, Christopher, be very careful with this soup. It's very hot, okay? Ow!
Barbara, get me the water. He's burned his hand on the soup. You need to pour this water on your hand just to cool it off. Okay, just relax. We're cooling it off here. Turn your hand over so we can cool off. Okay, Barbara, I need more water and a first aid kit. Let's go ahead and get your ring off. Okay, you can hold on to this. Let me get your watch off. Okay, let's get this wrapped up for you.
I can't believe I did this.
Oh, that's all right. We'll get it wrapped up and taken care of for you right here.
Thank you.
Not a pound me? Good girl. Okay. Are you okay? Are you choking? Are you choking? Oh, okay, just a minute. Come on, get out of your seatbelt. Come here. Come here, let me help you. Come here, let me help you. You'll be all right. Just a minute. She's gonna be all right. Just a second. Here we go. Oh, there you go. You feel better? Catch your breath. Come on, let's sit down. Have a seat right here. Just catch your breath, okay? Lean back. All right? You gonna be all right? Boy, that was scary, wasn't it? She'll be all right.
Oh, my gosh! Are you all right? Let me help you. Let's go. Let me help you. Don't move. Don't move. Let me see. Let me check your leg. Oh, my God. Renee! Renee, I need help. Give me the first aid kit. Don't move your leg. I want to see. Do me a favor and try to slightly push your foot into my hand.
I can't.
Just don't move your foot then. Don't move your leg. With that turbulence, the car went flying on top of the left leg. Yeah. Okay. Let's put it for you. Don't move. Try not to move. Can I wrap it? It'll be all right. Just try to relax. This down here. We're going to wrap it. Let me see if I can help you hold this. Oh, great. If you can help us, great. Got it? tap it. Take it easy. It'll be a couple minutes. You'll be feeling much better. All right, Renee, would you give me the oxygen bottle and a blanket, please? Okay, and I'll see if somebody notified the cockpit and also to see if there's any medical assistance on board. Okay, just try to relax. Take a few deep breaths through your mouth. We're going to need some information from you. Do you have your ticket? You know where your wallet and your ticket are?
In my inside pocket.
Let me help.
Try to relax. Take a deep breath.
Get this on you.
Take a deep breath.
Let's recline your seat a little bit, make you more comfortable. Okay. Take it. I'm going to put some oxygen on you.
I'd rather have a drink.
Okay, you'll be all right. Just a few minutes before you go on your flight.
Okay. Just relax. Breathe normal.
Deep breath.
Relax.
Excuse me, I think we have a problem here.
What's the problem? Oh, my word. Joyce, give me some pillows, please. I think she's having a seizure. I'm here to help you. Let's pad these. Can you get out of your seat? We'll just put these beside her. Help me on that side, okay?
Let me get some more pillows.
Okay, great.
I'll go tell the captain to get some oxygen.
That's great. Oh, Joyce, good. Did you tell the captain?
Yeah, notify the
captain. Great. Sniff it's okay?
Yeah.
I'll tell you what, I'll hold it on her mouth.
Okay.
And you put the band on. There we go.
Got it.
This should help. Can you hear me? Do you feel all right? We're trying to help you now. You can relax. I'm making sure her airway's open here. We'll get her nice and warm. All right? How are we doing here?
Very good.
Good. Okay.
Honey, are you okay? Honey, are you okay? Miss, flight attendant. Honey, are you okay? There's something wrong with my husband.
What seems to be the problem?
I don't know.
Are you okay? Are you okay? Barbara, I need your help. Let's open up this airway. I need you to get out of the way. Let me help you. Barbara, he's breathing, but we'll need to lie him down. Don't mind asking this. Thank you. Barbara, help me lay him down, get his feet. Okay, now we'll need to pull him down. Okay, if you'll notify the cockpit for me, get me an oxygen bottle, a blanket, and also see if there's any medical assistance on board.
Is he gonna be okay?
Okay, sir, the oxygen is here. We're going to be giving you some oxygen. I'm your flight attendant. Your wife is nearby. Take it easy. Put the oxygen on you. Okay, relax and breathe. Barbara, I need you and Paula right away. Something's happened to Joyce. Joyce.
What happened?
Okay, Paula, you're going to have to help us roll over. She was knocked unconscious. Okay, I'll take care of the head. Get her arms positioned. Okay, and on the count of 3, we'll roll her over. 1 unit. 1, 2, 3. Slowly. Slowly. Okay. Is she okay? Okay, she's breathing and has a strong pulse. Barbara, would you please notify the cockpit and bring me some blankets? Paul, I want you to get the first aid kit and an oxygen bottle, please. Okay, Joyce, we're taking care of you. It's going to be okay. Take it easy. Paul, if you get me a compress, bleeding.
Ladies and gentlemen, we need your attention. We have a medical emergency. If there is a doctor on board, please identify yourself to one of your flight attendants immediately.
Some pressure on that, and let's get the oxygen. Joyce, we're going to put some oxygen on you. Joyce, hold on. We're getting some help. Okay, Joyce. You're doing fine, Joyce.
She's doing
You okay?
I think she's coming to.
Joyce, she's coming around. Let's immobilize her neck. Hey, Joyce, how do you feel? Do you have any pain?
My head hurts.
Okay, I want you to try to wiggle your fingers, Joyce.
I can't feel my hands.
Okay, we're going to put some blankets on you and warm you here. Take it easy. Okay, take it easy, Joyce.
My arms are tingling.
I think she's okay.
Okay, can you move your feet?
No.
Can you move your feet?
Okay. All right, Joyce, we're here.
Just breathe. It'll be all right. They've called for help. Okay, Barbara got the pilots called for help, and we're going to have somebody waiting to meet the flight. Just as soon as we land, all right?
Take it easy. Breathe normally, Joyce. Breathe normally.
I'm going to check the vital signs. Barbara brought me this first care checklist.
Okay, Paula's getting your breathing rate and your pulse rate, Joyce.
Okay.
You're doing great. Hang in there.
Okay.
Okay, we're here with you. Just take it easy. Okay, just breathe normal.
Hi.
How's she doing?
She seems to be doing better. She's coming around.
Joyce, can you hear me?
Yeah.
We've taken the vital signs over here.
You can give those to the paramedics. Call us in, okay?
Okay, we've already contacted the paramedics. They're going to be meeting us. How are you feeling, Joyce?
You're going to be landing immediately?
Yes, the captain's planning on landing immediately.
Okay.
I'll call these in to the paramedics.
Okay, great.
You'll be okay.
I think I'm going to stay with her for landing.
I think I
Okay,
better
will
go
you be
up.
coming back
Yeah,
up
I'll
for
go
landing?
up.
Okay.
All right.
It's all right, Joyce. I'm going to stay with you.
Okay.
Take it easy. You're doing great, Joyce. You're doing fine.
Okay.
All right, I'll be here with you for landing. I'm not going to leave you.
Whenever a medical emergency occurs on one of your flights, the first care plan of ABC's Care should be initiated. Let's take a closer look at the first care steps you've just seen. To establish responsiveness, shake the person gently and shout, "Are you okay?" If there is no response, the person must be properly positioned. In this situation, a log roll is necessary. Notice the person is moved by the 3 flight attendants in unison. Your next step is to open the airway. The airway is opened and maintained by using the head tilt chin lift. The jaw thrust is used if there is a possible head or neck injury. If you suspect a person's airway is blocked and they are conscious, ask, "Are you choking?" If they are unable to respond verbally, position yourself behind them and administer abdominal thrusts until the foreign object is expelled. When a person is having a seizure, no attempt should be made to place anything in their mouth. When the seizure is over, clear the person's mouth and maintain an open airway. After the airway is open, the breathing process must be supported. If breathing is present and the person is conscious, position them comfortably and administer oxygen. If the person is unconscious, the best position for them is lying down, and then administer oxygen. The next step in the plan is to support circulation. You can do this by monitoring the carotid pulse, keeping the person at rest, covering with a blanket to maintain body heat, and elevating the feet when necessary. If bleeding is present, apply direct pressure with a dry, sterile dressing for at least 15 to 30 minutes. Once applied, never remove the dressing. The primary care for all burns is to stop the burning process. Pour cool water over the burn and wrap with a dry, sterile dressing. Remove restricting jewelry if necessary. If you suspect a head, neck, or spinal injury, immobilize the head and neck. Surround with pillows and blankets for additional support. Do not move the person or elevate feet. Administer oxygen and keep warm. Your communication with the person, other crew members, and bystanders is vital to the plan. Get the story by asking questions. Tell the person what you're doing. Notify the cockpit and seek medical assistance. Record whatever care you give. Then complete all necessary forms. Avoid harm when providing first care to an ill or injured person. No food or drink should be given to a seriously ill or injured person. There is an exception. A diabetic who is feeling ill should be given sugar in the form of sweetened orange juice or a soft drink. Sudden improvement should occur. If the person continues to feel ill or becomes unconscious, immediate medical attention and a flag stop may be necessary. Do not give anything by mouth to the unconscious person. Medication can only be administered by a qualified physician. If a fracture is suspected, immobilize the limb by applying a splint. Secure the splint at the joints above and below the break. If the person is having a seizure, relocate nearby customers and pad the area to protect the person from injury. Make no attempt to restrain them. Re-examination of the ill or injured person is an ongoing process. Remain with the person and continue to provide life support by monitoring the ABCs. Measure and record vital signs. Encouragement can relieve fear and anxiety, as well as support a person's will to live. Remain calm and reassure the person and their loved ones that you're doing everything possible to help them. Remember, even the unconscious person will hear and react emotionally to all that is said around them. Your capable and confident actions when providing first care to support the functions of airway, breathing, circulation, and spine may significantly improve the chances for an ill or injured person's recovery. If there is a medical emergency on one of your flights, use the first care plan to support life. You can do it.
what I'm feeling.
Well, I know what you're feeling. You're feeling...
Concepts in Emergency Care presents CPR for laypersons. Having a heart attack is one of the most frightening things that anyone can imagine. Over 500,000 persons die from cardiac arrest every year in the United States. In fact, heart disease accounts for almost 1 million deaths every year. That's about half the total number of deaths annually in the United States. But frightening as these statistics are, there are things you can do to lessen the chances of having a heart attack. And should you have one, there are things you can do that will increase your chance of survival. There are some factors that increase the risk of heart attack that cannot be changed. These are heredity, sex, race, and age. If there is a history of heart disease in your family, you are at risk of having heart disease yourself. Men are more at risk than women, blacks more than whites, and risk for all groups increases with age. But even these high-risk factors can be lessened because there are many risk factors that can be controlled. These factors include cigarette smoking, high blood pressure, elevated cholesterol, coffee and alcohol consumption, and diabetes. Each of these has been shown to increase the risk of heart attack. So by not smoking, controlling your blood pressure and cholesterol intake, you can reduce your risk of heart attack. And if you are diabetic, controlling the condition will reduce your risk. The benefits of controlling these risk factors increase with time, and it's never too late to start. For example, even if you have been a heavy smoker for many years, stopping will reduce your risk almost immediately. Even those who are in a high-risk group will lower their risk by controlling these factors. Controlling these risk factors not only reduces your risk of heart attack, but of stroke too, since heart attack and stroke both have the same cause. Both heart attack and stroke are caused when small arteries become blocked, preventing blood from reaching the cells that the artery supplies. When this happens, these cells begin to die. If it's an artery in the heart, then it's a heart attack. If the artery is in the brain, then it's a stroke. Arteries become blocked as fatty deposits begin to line the artery wall. As these deposits build up over time, they can narrow the artery. Eventually, the artery can become so narrowed that it will shut off. This happens in several ways. The fatty deposits close off the artery as the artery normally constricts, or a clot forms because blood is moving very slowly through the narrowed artery, and the clot blocks off the artery. When this happens, the cells that depend on that artery for blood die. Smoking, high blood pressure, and high cholesterol all put a strain on the heart and arteries, making the situation worse. In addition to prevention, you should know what to do when someone is having a heart attack. When a heart attack occurs, fast action is important. The faster the patient gets to the hospital, the better the chances of survival. A sign of a heart attack is severe, prolonged chest pain, usually in the center of the chest. The pain may also be felt in the arms, neck, back, and jaw. This pain is usually described as a crushing pressure. In addition to pain, there may be profuse sweating, nausea, and shortness of breath. The patient may feel suddenly weak and be anxious and feel an impending sense of doom. Not everyone experiences all these signs. They can come in any combination. It is common for a person having a heart attack to deny that it's happening. The person may think that it is indigestion and that it will go away. This denial is often fatal. The longer a heart attack goes on untreated, the worse it is likely to be. If you or someone you're with has any of these symptoms, don't wait. Call an ambulance. It may not be a heart attack, but why take a chance? Remember, recognition and fast action are the keys to helping a person having a heart attack. A heart attack can lead to cardiac arrest. When this occurs, you must be prepared to start cardiopulmonary resuscitation, CPR. Heart attack is not the only cause of cardiac arrest. Cardiac arrest can also occur when the airway is blocked, preventing air from reaching the lungs. Drowning and airway obstruction are examples. Cardiac arrest can also result from electrocution. The remainder of this program will teach you CPR and a method for relieving airway obstruction called the Heimlich maneuver. You will learn these techniques for adults, children, and infants. These techniques are known as basic life support. When the heart stops beating and breathing ceases, the victim is said to be clinically dead. In this state, oxygen is not reaching the cells of the body because blood is not circulating and the victim is not ventilating. If circulation and ventilation are not restored within 4 to 6 minutes, cells begin to die and the victim is said to be biologically dead. CPR, cardiopulmonary resuscitation, is the first method used to try to restore circulation and ventilation. When you begin CPR, you are attempting to replace the automatic functioning of the heart and lungs by manually compressing the chest and ventilating the victim. You are attempting to oxygenate and circulate the blood. Whether cardiac or respiratory arrest occurs first does not matter. One will lead to the other very quickly. The common causes of respiratory arrest include airway obstruction, drowning, drug overdose, suffocation, and toxic environments. Cardiac arrest is commonly caused by coronary disease that leads to a heart attack. For CPR to be effective, speed is essential. The faster cardiac arrest is recognized and CPR started, the more effective it is likely to be. Ideally, help should be called and CPR begun within 4 minutes of the arrest. Your goal must be to get the patient definitive cardiac care fast. The best salvage rates are achieved when advanced cardiac life support is started within 8 minutes of the arrest. The first step in giving CPR is finding out if the patient is in arrest. To do this, you should remember A, B, C. A, airway, B, breathing, C, circulation. To establish if the patient has an open airway, first see if the patient is unconscious and unresponsive. To find out, tap or gently shake the patient and shout, "Are you okay?" If the patient is unresponsive and unconscious, immediately send for help. You must get someone to call the ambulance. If no one is around, you will have to do it yourself. Don't delay. Get an ambulance fast. If you suspect that the patient has a head, neck, or back injury, do not move the patient unless absolutely necessary. Establish whether the patient is breathing spontaneously. This is easily done by placing your ear over the patient's mouth and nose so that you can hear and feel air moving in and out. At the same time, look at the patient's chest to see if it rises and falls. You should look, listen, and feel for air exchange. This should take only 3 to 5 seconds. If the patient is not breathing, you will have to open the airway. To do this, the patient should be placed on his back or a hard, flat surface with his arms at his side. A hard, flat surface is essential for CPR to be effective. If the patient is face down, he will have to be rolled onto his back. This should be done in such a way that the head and torso remain in line and the body is rolled as a unit. Once the patient is correctly positioned, you should kneel at the patient's shoulders. This position provides easy access for both rescue breathing and chest compressions. Now you are ready to open the airway. Maintaining an open and clear airway is essential for successful resuscitation. Opening the airway serves to move the tongue away from the back of the throat. This prevents the tongue and/or the epiglottis from obstructing the airway. Obstruction of the pharynx by the tongue and the larynx by the epiglottis are the most common causes of airway obstruction in the unconscious patient. This type of obstruction can also occur when negative pressure is created during inhalation, as the entrance to the trachea is occluded. Sometimes opening the airway is all that is needed to restore spontaneous ventilation. The primary method used for opening the airway is called the head tilt chin lift maneuver. To do this, place one hand on the patient's forehead and with the palm press on the forehead, tilting the head back. At the same time, place the index and middle fingers of your other hand under the jawbone at the chin. Use these fingers to lift the chin, bringing it forward until the teeth almost close. This will support the chin and help tilt the head back. As you do this, be careful not to press too hard under the chin, as this could obstruct the airway. 2 notes of caution. First, the thumb should never be used, and second, be careful not to close the mouth completely. If the patient has dentures and they are so loose that they cannot be kept in place, remove them. Once the airway is open, again look, listen, and feel for air exchange. If the airway has fluid, vomitus, or any other foreign matter, it must be cleared. This can be done with a small dressing wrapped around your index and middle fingers. If and when available, suction should be used. Solid material can be removed using a hooked finger. If the patient resumes spontaneous ventilation once the airway is opened, continue to keep the airway open and clear. If the patient is not breathing, he is in respiratory arrest and you will have to breathe for him. The method used to do this is called mouth-to-mouth ventilation. While using the head tilt chin lift to keep the airway open, pinch the nostrils shut using the thumb and index finger of the hand on the patient's forehead. This will prevent air from escaping through the patient's nose. Now take a deep breath and seal your lips tightly around the patient's mouth. Give 2 full breaths, one at a time. It should take only 1 to 1 1/2 seconds to give each breath. You should take a breath after each ventilation. Your ventilations are effective if you see the patient's chest rise and hear and feel air escape during exhalation. Be careful not to use too much force, as this will cause air to enter the stomach, creating gastric distension. Gastric distension will make ventilation difficult and ineffective. If you cannot ventilate the patient, reposition the head and again attempt to ventilate. A closed airway is the most common reason for ineffective ventilations. If you still cannot ventilate, the airway is obstructed and will have to be cleared. The technique for this will be demonstrated later. Sometimes mouth-to-mouth ventilation will not work. This can be due to injury around the mouth that prevents a good seal, or if the patient's mouth cannot be opened. In such cases, mouth-to-nose ventilation can be used. In mouth-to-nose ventilation, keep the airway open with the head tilted back, but use the hand on the patient's chin to close the patient's mouth. Take a deep breath and seal your mouth around the patient's nose and blow into it. Then remove your mouth and allow the patient to exhale through the nose. It may be necessary to open the patient's mouth to assist in exhalation. There are patients who have had their larynx removed. These patients breathe through an opening called a stoma on the front base of the neck. These patients must be ventilated through the stoma. This is done by placing your mouth around the stoma and blowing in. After the ventilation, remove your mouth and allow the patient to exhale through the stoma. Other patients have a temporary tracheostomy tube in the trachea. To ventilate these patients, the nose and mouth must be held shut and ventilations given through the tube. In either of these patients, it is not necessary to maintain an open airway by the head tilt chin lift method, as both these patients have openings directly to the trachea that bypass the normal airway. After giving 2 breaths, it is time to check the patient's pulse to see if he is in cardiac arrest as well as respiratory arrest. Because peripheral pulses are difficult to palpate in the patient whose system is depressed, a central pulse is used. The pulse that should be used is the carotid. A carotid artery is located in the groove between the trachea and the large muscles on either side of the neck. To find the carotid, maintain the head tilt. Use 2 or 3 fingers of the other hand to locate the larynx. Then slide these fingers down into the groove between the trachea and the large neck muscles. Press gently and you should feel the pulse. Allow 5 to 10 seconds to find the pulse, as it may be weak or irregular. Take the pulse on the side nearest you. Never press both carotids at the same time. This could occlude the blood supply to the brain. If you find a pulse but the patient remains in respiratory arrest, you should continue to breathe for the patient at the rate of 1 breath every 5 seconds, 12 breaths a minute. If no pulse is present, you will have to begin CPR. After delivering the 2 initial ventilations and determining that no pulse is present, you must begin to give chest compressions. Chest compressions serve to circulate the blood. Remember, the patient must be on a hard, flat surface for compressions to be effective. If possible, elevate the patient's legs. This may help venous return during compressions. The first step in giving chest compressions is to achieve the correct hand position. In order for compressions to be effective, the correct hand position must be found and maintained. Begin by baring the chest. Cut away all clothing, including underwear, covering the chest. Now, with your index and middle fingers of the hand closest to the patient's feet, find the lower margin of the rib cage on the side of the patient closest to you. Then move your fingers up along the rib cage until they are at the notch at the center of the rib cage where the ribs and the sternum meet. Place your middle finger on the notch and put your index finger next to it directly on the sternum. Next, place the heel of your other hand directly on the patient's sternum next to the index finger. Then take the first hand away from the notch and put it on top of the other hand so that both hands are parallel to each other. You can either extend or interlace your fingers, but your fingers must not touch the chest. An alternate method that may be more comfortable for some is to grasp the wrist of the hand on the sternum with the other hand. Your body, as well as your hands, must be in the right position to give effective compressions. The correct position not only ensures that compressions will be effective, but that you will minimize fatigue and therefore be able to continue CPR for an extended period. Your elbows should be locked with arms straight. Your shoulders should be directly over your hands on the sternum and your knees right up against the patient's side. This will ensure that each compression will be straight down. Compressions that are not straight down will not be as effective. You should compress the chest 1.5 to 2 inches. After each compression, allow the chest to rise fully. This allows blood to flow to the heart. Compressions and releases should be of equal length. As you release the compression, your hands should not come off the chest. You must maintain the same hand position for the whole compression cycle. The compression should be delivered with your entire body. Avoid bouncing on the chest as you compress and release. Chest compressions should be given at the rate of 80 to 100 per minute. In one responder CPR, you should give 15 compressions, then 2 ventilations. Give compressions as you count out loud. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12 and 13 and 14 and 15. Then open the airway and deliver 2 ventilations. Now re-establish your hand position on the chest and give 15 compressions at the rate of 80 to 100 per minute. Continue giving 15 compressions followed by 2 ventilations for 4 cycles. After 4 cycles, check the carotid pulse. Allow about 5 seconds for this check. And check for spontaneous breathing. Allow about 5 seconds for this. If a pulse is found, but the patient remains in respiratory arrest, continue mouth-to-mouth ventilation at the rate of 12 breaths per minute. If no pulse is found, continue CPR. 15 compressions, then 2 ventilations. You should check for spontaneous breathing and pulse every few minutes, but you should not stop CPR for more than 7 seconds. Once CPR has been started, it should continue until the patient regains spontaneous circulation and respiration, or you are relieved by other responders, or a physician finds the patient unresuscitable, or you become exhausted and unable to continue. Let's review the steps for one responder CPR. 1. Establish unresponsiveness and lack of spontaneous breathing. 2. Call for additional help. 3. Position the patient and open the airway. 4. Give 2 breaths. 5. Check for a carotid pulse. 6. Position your hands on the chest and give 15 compressions at the rate of 80 to 100 per minute. 7. Then open the airway and give 2 ventilations. 8. Give 4 cycles of compressions and ventilations. 9. Check for spontaneous circulation and respiration. 10. Continue CPR, checking pulse and breathing every few minutes. CPR for children and infants requires some modification of technique. For children under 8, mouth-to-mouth ventilations should be given at a rate of 15 per minute, 1 every 4 seconds. Chest compressions should be delivered using the heel of one hand. The chest should be compressed only 1 to 1 1/2 inches. Compression should be given at a rate of 80 to 100 per minute. The ratio of compressions to ventilations should be 5 compressions to 1 ventilation. Remember, remove your hand from the child's forehead when giving chest compressions. When opening the infant's airway using the head tilt chin lift method, it is not necessary to extend the head too far back. Overextension should be avoided. When giving mouth-to-mouth to an infant, your mouth should seal around both the mouth and nose of the infant. You should deliver the initial 2 breaths and all subsequent breaths slowly, 1 to 1½ seconds for each breath. You will know if the breaths are of sufficient force and volume if you see the chest rise. If the infant is in respiratory arrest, breath should be given at a rate of 20 a minute, 1 every 3 seconds. Check the pulse on an infant by palpating the brachial artery. The brachial pulse is located on the inside of the upper arm. Use the index and middle fingers to gently press until a pulse is felt. To give chest compressions to an infant, first locate the correct point on the chest. This is done by placing your index finger right between the infant's nipples and directly on the breastbone. Now place your middle and ring fingers next to your index finger. The point where your middle and ring fingers lie is the point for compressions. When giving compressions, use 2 or 3 fingers to compress the chest 1/2 to 1 inch. After each compression, allow the chest to fully rise. Compressions and releases should be of equal duration. Compression should be given at a rate of 80 to 100 per minute. After every 5th compression, 1 ventilation should be given. The infant should be reassessed after 10 cycles and every few minutes after that. Let's review the steps in infant CPR. 1. Determine unresponsiveness and absence of breathing. 2. Position the patient on a firm, flat surface. 3. Open the airway using the head tilt chin lift or jaw thrust. 4. Look, listen, and feel for air exchange. 5. Give 2 slow breaths. Cover both the infant's mouth and nose with your mouth. 6. Check the brachial pulse. 7. Find the proper position for compressions, 1 finger width below the nipple line on the breastbone. 8. Compress the chest 1/2 to 1 inch at a rate of 80 to 100 compressions per minute. 9. Give 5 compressions and then 1 ventilation. 10. After 10 cycles, check pulse and respiration. Continue CPR and recheck every few minutes. A major problem in giving CPR is gastric distension. This is caused by air entering and inflating the stomach. When this happens, the pressure of the inflated stomach can make it difficult to ventilate the patient. Keeping the airway properly open and ventilating slowly will help prevent gastric distension. Usually you should not attempt to relieve moderate distension, as it is likely to cause the patient to vomit. However, should gastric distension become so severe that it prevents proper ventilation, you can attempt to relieve it. This is done by rolling the patient onto the side and pressing gently on the stomach. Be prepared for the patient to vomit. Remember, too, that for ventilation to be effective, the airway must be open. If you feel resistance when you ventilate, reposition the head and try again. An improperly positioned airway is the prime cause of inadequate ventilation during CPR. When performing chest compressions, it is important to maintain the correct hand position. If compression is applied to the lower end of the sternum or directly to the ribs, these structures could fracture and cause severe damage to the heart, lungs, liver, and spleen. Ruptured organs will cause massive internal bleeding. A ruptured lung will result in a pneumo or hemothorax. Care must also be taken that compressions are smooth and regular, and that compressions and releases are of equal duration. Rocking or jabbing can cause internal injury. When giving CPR, there are several special situations that you should note. When CPR must be performed on a drowning victim, it is essential that the victim be removed from the water before CPR can start. For while the patient can be ventilated in the water, chest compressions will be ineffective unless the patient is on a hard surface. When performing CPR on a multiple trauma victim, be especially careful to guard against overextension of the neck, as neck injury must be suspected in almost any severe trauma. And of course, you will have to treat the traumatic injuries as well, particularly bleeding. With a victim of electric shock, you must be careful that the scene is safe. Be certain that there is no danger of electrocution. The best precaution is to have the victim moved away from the hazardous area before beginning CPR. Victims who are in arrest as a result of hypothermia should be treated as any arrest victim, given CPR and transported. When checking the pulse, allow up to 1 minute, as the blood flow will be reduced and it may require extra time to palpate a pulse. Remember that for ventilations to be effective, the airway must not be obstructed. Often, cardiopulmonary arrest can cause the upper airway to obstruct. When the patient is unconscious, the tongue and epiglottis can block the airway. Opening the airway should relieve this kind of obstruction. In addition, vomitus and blood can obstruct the upper airway. Airway obstruction caused by a foreign body is another matter. When food or other small objects get trapped in the airway, it can occlude the airway and lead to a respiratory arrest and then cardiac arrest. Airway obstruction can be either partial or complete. If the patient's airway is partially obstructed, but the patient is moving air well, the patient will be coughing with force. And although there may be wheezing between coughs, you should not attempt to clear the airway. You should encourage the patient to cough to try and clear the obstruction. But remember, a partial obstruction can become a complete obstruction very quickly. If the patient is partially obstructed and not moving air well, or is fully obstructed, you will have to take immediate action to remove the obstruction. The patient who is partially obstructed and not moving air well will be coughing weakly. A high-pitched noise will be heard on inspiration, there will be marked difficulty in breathing, and the patient may be cyanotic. The patient who is fully obstructed will be unable to speak, breathe, or cough. The patient may clutch his throat. The patient who is fully obstructed is only moments away from arrest. When someone is obstructed, you must act fast to remove the obstruction. This is done using the Heimlich maneuver. The Heimlich maneuver is a sharp thrust to the victim's abdomen. The abdominal thrust causes the diaphragm to rise, which in turn forces air from the lungs in enough quantity to push the obstructing object from the airway. It may take several abdominal thrusts to dislodge the object. To give abdominal thrusts to a patient who is standing or seated, stand behind the patient and wrap your arms around the patient's waist. With one hand, make a fist and place the thumb side on the patient's abdomen. The fist should be in the middle of the abdomen, about an inch above the navel. You must be very careful to keep the fist below the xiphoid process, which is at the lower end of the rib cage. Compression of the xiphoid could cause it to break and damage the organs that underlie it. Next, grasp the fist with your other hand. Then press your fist into the patient's abdomen with a quick upward thrust. Continue giving these thrusts until the object is expelled or the victim becomes unconscious. When a victim is obese or in the advanced stage of pregnancy, chest thrusts can be used. To perform chest thrusts with a standing or seated patient, stand behind the patient. Pass your arms through the patient's armpits and around the chest. With one hand, make a fist. Put the fist thumb side down in the center of the patient's breastbone. Grab your fist with your other hand and compress the chest. Continue giving chest thrusts until the object is expelled or the victim becomes unconscious. When placing your hands for chest thrusts, be sure they are in the middle of the breastbone and not near or on the xiphoid process. If the obstructed victim is unconscious, the Heimlich maneuver should be performed as follows. Place the victim in a supine position. Then straddle the victim at the thighs. Place the heel of one hand in the middle of the abdomen, slightly above the navel. Be careful to keep the hand well below the xiphoid process. Place the other hand on top of the first hand. Then press the abdomen with a quick upward thrust. After 6 to 10 thrusts, you should do a finger sweep. To do this, use your thumb and index finger to grasp the patient's tongue and jaw. Then lift. This will open the patient's mouth. Now, using the bent index finger of your other hand, attempt to dislodge the object and move it into the mouth where you can remove it. Be careful not to push the object deeper into the airway. The finger sweep should take only a few seconds. After the finger sweep, attempt to ventilate the patient. If you cannot ventilate, continue with abdominal thrusts. Here are the steps to follow in clearing an airway obstruction in a victim who becomes unconscious. 1. Use abdominal thrusts until the obstruction clears. 2. Open the victim's mouth and do a finger sweep. 3. Attempt to ventilate the victim. 4. If unable to ventilate, do 6 to 10 abdominal thrusts. 5. Do a finger sweep. 6. Attempt to ventilate. 7. Continue the sequence of thrusts, sweeps, and ventilations until the obstruction is cleared. In clearing an airway obstruction in a child, the same technique as for an adult should be used, with 3 minor exceptions. Abdominal thrusts should be of less force. The thrusts on an unconscious child should be given from the side of the patient, not while straddling the child. And the finger sweep should not be used, as it could push the object deeper into the airway. Instead, open the child's mouth, and if you can see the object, remove it. For clearing an airway obstruction in an infant up to 1 year old, the Heimlich maneuver is not used. Instead, place the infant so that it straddles your arm. While supporting the infant's head by holding the jaw with the head lower than the trunk, give 4 firm back blows with the heel of your other hand directly between the infant's shoulder blades. Then, with the infant sandwiched between your arms and hands, turn the infant over. Now, with 2 or 3 fingers, give 4 chest thrusts. These are given in exactly the same place as you give compressions for CPR, about an inch below the nipple line, directly on the breastbone. However, these thrusts should be given at a slower rate. If the infant is conscious, continue back blows and chest thrusts until the obstruction clears or the infant becomes unconscious. If the obstructed infant is or becomes unconscious, use the following procedure. 1. Using your thumb and index finger, hold down the infant's tongue and open the mouth. If you see the object, remove it. Do not do a finger sweep. 2. Attempt to ventilate. 3. Give 4 back blows, then 4 chest thrusts. 4. Attempt to clear the airway and ventilate. 5. Continue to give back blows and chest thrusts and attempt to clear the airway and ventilate until the airway is clear. If you are the one who is obstructed and there is no one around to perform the Heimlich maneuver, you can do it for yourself. This is done by using your hands to give yourself abdominal thrusts. One hand, as a fist, is placed above the navel with the other hand over it. Then press in and up with quick thrusts. If this does not work, firmly press your abdomen over a chair back or table edge or fence. Continue doing this until the obstruction clears. By learning, practicing, and refreshing these skills, you will be ready to save a life.
This is a global international charter flight carrying television newsmen and technicians from Brasilia Airport, December 4th, 1982. For a better understanding, one of the newsmen on board explains what happened.
The shock of the impact sent bags and briefcases flying around the cabin. The oxygen masks tumbled out of their storage compartments. Overhead panels were jarred open, exposing cables and wiring. Someone said there was a hole in the left wing. Moments later, Captain Gary Edwards came on the intercom and told us that we'd hit a light stand at the end of the runway. We would have to unload about 40,000 pounds of jet fuel before attempting a landing at Brasilia Airport. The flight crew briefed us on emergency procedures. One camera crew shot some videotape inside the plane as we circled the airport. The pilot made a low pass over the tower so the controllers could inspect the condition of the aircraft. A woman up front was crying, and a friend sitting behind me moved up to comfort her. There was no panic, but there was fear. After nearly 2 hours, the crew instructed all passengers to prepare for an emergency landing. We were ordered to assume the crash position. Hands grasping ankles, heads on our laps, faces buried in seat cushions. The captain came on the intercom and said, 5 seconds to touchdown. The sound and the vibration of the landing were terrifying. We quickly left the airplane through the rear emergency exit. People tumbled into each other on the evacuation chute. Emergency crews raced to the crash site to hose down the plane.
Since Global is a U.S. carrier, a thorough investigation of this accident will be conducted by the National Transportation Safety Board. They will inspect the aircraft, interview passengers, pilots, and other crew members, and in 8 to 12 months, they will issue their findings in a publication report like this one. We will then be in a better position to determine what went wrong, why, and what are we doing that's working and not working to better prepare for similar emergencies. In fact, most emergency procedures as we see them implemented and changed are a result of these types of investigations. 1982 saw dramatic changes in safety procedures as the emphasis shifted from the planned emergency to the unplanned and wanted. On January 13th, 1982, Air Florida Flight 90, a Boeing 737, was departing Washington National Airport for Fort Lauderdale, Florida. The flight was delayed approximately 1 hour, 45 minutes due to heavy snowfall, which necessitated the temporary closing of the airport. This photo, taken by a visitor before departure, is evidence of the poor conditions. Before takeoff, the 737 was de-iced several times, and according to the NTSB report, it was excessive icing that caused the aircraft to crash into the Potomac River just after takeoff. Like most accidents, the mishap was quite sudden. Passengers and crew had no time to prepare. Kelly Duncan, the only surviving crew member, recalls what happened.
And I had just finished taking drink orders, and we were late, and the passengers were frustrated. And I just took my seat, and the captain made a call for the flight attendants to be seated for takeoff. And we took off, and as we started to go down the runway, instead of speeding down the runway, we dragged off the runway. We just barely lifted up. And it just took a long time. I remember thinking, gosh, it's taking a long time to get up. And when we finally did get up, my first thought was relief, just glad to be up, because I was a little bit nervous about the delay in the takeoff. And as soon as I felt that relief, all of a sudden the plane just started to shudder, just violently. You could just hear everything shaking in the bins. There was no noise from any passengers or anything, just violent shaking in the cabin. And then from that, the next thing I knew, I was just disoriented. I didn't know where I was, and the next thing I knew, I was just in the water. And when I found myself in the water, I really wasn't aware it was water, I don't think, but I was just kind of disoriented, and I started moving around, and I came to the top of the water, and when I surfaced, I saw the tail of our airplane in the water, and, you know, I was shocked.
69 passengers sustained fatal injuries on impact. For the 6 occupants who escaped from the aircraft, water temperature and air was a major factor which affected their survivability. Water temperature 4 feet below the surface that day was 34 degrees. The survivors were in the icy water from 22 to 35 minutes before being rescued. Under these conditions, 50% of the survivors should have lost consciousness in this amount of time. Only 1, however, lost consciousness and drowned. The remaining 5 reported that the cold was so intense that they quickly lost effective use of their extremities.
When I tried to get to the airplane, I couldn't swim, and I was panicked. Because I thought I was okay, and it wasn't really from pain, it was just, I just couldn't swim. I started to feel myself go under, and I was panic-stricken, so by the time I finally did reach my little section of metal, I wasn't going to let go for anything. I was just really clutching on to the thing that I had. My hands started freezing to the metal, and then I started thinking, well, if we live through this, we're going to have our limbs cut off. I was thinking, I know it's a crazy thought, but I was thinking my legs are going to have to be cut off. And I was thinking, I don't want my legs to be cut off. And I was looking at my hands, and they were like frozen. You could see the blood had stopped flowing in them, and I was having to peel my hands off and shake this hand, and then put this hand back on and peel this hand off and shake it. And all I could think about was I'm just going to keep moving, and I started hanging on and kicking, like if I was kicking in a swimming pool. Just trying to keep moving, and I didn't want to sit there and freeze. The water was just so intensely cold, and it was hurt. It hurt because it was so cold. The helicopter came, and first of all, they came, and I saw them kind of go past me, and all I could think about was I wanted out. I wanted, to be out right away. And they came back over to me, and they dropped a rope, and it had a loop on it, and I was hanging on with this hand, and I reached up to my hand, and the loop kind of just went right over my shoulder. And I pulled from the loop going around my shoulder, I pulled the rest of it around my back, and held on to it like that, and just looked up at them and kind of told them I was ready, and they pulled me out. And as weak as I felt in the water, and as panicked as I felt in the water, I in no time felt like I was going to let go of that rope. In fact, they had to pry the rope out of my hands when they got me over to shore.
The effects of hypothermia are very obvious here. The reason victims found it difficult to swim are clear: a rapid loss of body heat. Moving about in cold water is everyone's answer to keeping warm, but we know this is a myth. This rapid movement only speeds up the loss of body heat, with no means to replenish it. And the cold need not be extreme. Hypothermia can occur in water temperatures up to 70 degrees. The colder the water temperature, the more rapid the effects of hypothermia, and the more movement, the same result. Flight 90 was not the first jet accident involving water, and not the last. Just 10 days later, on January 23rd, another commercial jet encountered water, and again, the elements played a major role. It was approximately 10 o'clock at night and snowing in Boston when World Airways Flight 30 landed at Logan Airport. According to the preliminary investigation, the DC-10 failed to decelerate sufficiently to remain on the runway. The aircraft skidded over an embankment into Boston Harbor. The forward section of the fuselage at about row 1 separated as the aircraft came to rest. The flight deck crew was quickly underwater but managed to escape. The 2 flight attendants seated at L1 and R1 found themselves underwater after the R1 door collapsed. The L1 flight attendant tried to get her life vest from her jump seat. She managed to don the vest despite the fact that her hands were so cold. As the R1 flight attendant swam to join L1, she saw 2, maybe 3 male passengers in the water. When the captain appeared, L1 and R1 followed him to the fuselage and were helped into the cabin by passengers. The remainder of the aircraft stayed intact, and with the exception of 2 missing passengers, the evacuation was accomplished successfully. The 2, 3, and 4 doors were opened and slides deployed. Initially, the number 2 engine remained in reverse thrust at high power for an extended period, and this delayed exiting from the aft slides.
How did you get out?
We first opened the first the first door, and someone slid out the first one, and he slid off, and then he went into water over his head. And two guys jumped down and got him out, and dragged him out, and I was there. And then we waited a little while longer, and we went to the next door, and we slid down there onto the wing, and then from the wing we jumped into water about waist high, and we just walked to the land.
How long before you had help out there in terms of assistance,
I was
ambulance,
standing
police?
out in the cold for 45 minutes, to tell you the truth.
45 minutes from impact to rescue, despite the fact that the accident occurred at a major airport. The water temperature was 30 degrees, and there was a wind chill factor. All those who were submerged in the water were treated for hypothermia. The two passengers missing were presumed drowned, and very possibly from the effects of hypothermia. A passenger sitting at a window seat, 15H, describes the activity in the main cabin.
I was thrown down and forward. The impact was more severe than a hard landing. The lights went out, but within seconds, other lights came on. When I sat up, I could see the pier and land behind. I unbuckled my seatbelt, grabbed my life vest and seat cushion. I helped the passenger next to me and told her to remain calm, that the flight attendants would tell us what to do.
There's no question that most passengers rely on the flight attendant in a crisis. The question we must ask is, are we prepared for that crisis? Do you ask yourself what flotation devices are available, vests or cushions? Do you know the correct positive commands that passengers admittedly want to hear should you find yourself in water? Will you have the presence of mind to detach the slide before opening the door so you can deploy it for water? Are there rafts on board? And where is the closest one?
One thing that I do now that I never did before is I think before when I'd be taking off, I might have been thinking about, you know, clothes or guys or something else. But I think now I really take the time out to give myself kind of refresh my memory on what I'm going to do, kind of prepare myself and just be prepared, because I wasn't prepared at all. I was thinking about a million other things when we took off.
On February 8th, a Japan Airlines DC-8 with 124 passengers landed in Tokyo Bay, short of the runway. 24 of the passengers died after the aircraft struck landing lights and went into the water without warning. A portion of the forward section, including the flight deck, was severed from the aircraft and was under the remaining fuselage when the plane came to rest. The flight crew escaped, but were in serious condition. The fact that it was daylight, good weather, and the water was shallow helped speed the evacuation. As of this programming date, there have been issued no official reports. Preliminary investigation, however, indicates that the captain, due to a sudden illness, caused the plane to nosedive on approach to Tokyo Airport. The first officer, an engineer, tried frantically to pull the aircraft up, but could barely level off as they struck the landing lights and went into the water. Flight attendants reportedly did an excellent job of evacuating. All survivors donned their vests and exited orderly. Some officials say that after a while, boarding the life rafts and boats appeared almost casual. This is a stark contrast to the accident in Boston just 11 days earlier, and in Washington just 10 days before that. The fact that 3 commercial carriers were involved in unplanned water landings in the short span of just 21 days had a sobering effect on our industry. As a result, we can be certain to see changes and improvements in training to help us prepare. But understand that real preparation is that short period of time spent on a jump seat.
Our news continues.
takeoff station. We've a full emergency. I repeat, a full emergency.
At 0712 hours on the 22nd of August 1985, an aircraft packed with holidaymakers began its takeoff from the north of England's international airport, Manchester. Its destination was the Greek island of Corfu. Minutes later, 54 people were dead and 60 injured after flames had engulfed the fuselage. The news and scale of the disaster stunned Britain. Government ministers and officials visited the scene and heard the experiences of survivors.
It was just an explosion. It's a loud bang. Thought a tyre had gone, and the pilot, you know, immediately put the brakes on straight away, really stamped the brakes on. Looked out the window, just sort of see how fast we were slowing down, that sort of thing, and see all flames coming out of the engine. So as soon as he pulled up to a halt, we thought it was going to blow up because it was full of fuel. The tanks must have burst over because there's a lot of fuel out onto the runway, and people were sort of like panicking, saying, people saying, get back in your seat, so everybody sat back down. But we thought it'd go out, the extinguishers on the plane. We actually straight away the foam tenders come and started spraying it. That was basically probably within a minute and a half of it happening.
How long did you have to get off the plane?
Well, we were off fairly quickly, 2 or 3 minutes, I suppose. Before it started filling up with smoke too much, we were getting off then.
What was it like when you got out and you realised what was happening to the plane and that people were still trapped inside?
It was pretty frightening, really. I just kept running across the field, I suppose. I didn't really look back until I was quite away from it. I suppose I was frightened of the whole plane going up.
To assess the extent of the fire, the crew sought advice from air traffic control, and passenger evacuation was recommended on the starboard side of the aircraft. Takeoff was immediately abandoned. An announcement was made of the public address system to evacuate using the right side exits. As the aircraft stopped, the left engine fire drill was actioned and the right engine shut down.
The first indications of an engine malfunction are likely to have come on these instruments here, which the pilot would be monitoring along with all the other instruments during takeoff. The next possible step with a fire would show on a small light here of an engine overheat. He can then use the engine fire checklist, which shuts down the engine, fires off the extinguishers into that engine, once again known off by heart and rehearsed and practiced regularly. The next step is much more difficult, and that's the emergency evacuation, which requires assessment and is quite complicated.
The cause of the fire was an uncontained failure of the left engine, initiated by the explosive rupture of number 9 combustor can. A section of the can had struck an underwing fuel access panel, causing fuel leakage, which was ignited by hot gases from the engine. Fuel was forced into the strong, turbulent wake by the extended thrust reverser buckets and burnt vigorously. As the aircraft slowed down on the runway, the fire was fully established, leaving a trail behind. The engine's fire extinguishing system had no significant effect, as in the main the fire was external to the engine. Within 20 seconds of the aircraft stopping, fire had spread via the cargo hold and through air conditioning grills located on each side of the fuselage. The main factor controlling the fire's behavior was the positioning of the aircraft in relation to the wind, even though the wind was light. The wind direction carried the external fire against and beneath the rear fuselage, creating rapid penetration of the cabin interior. By now there was panic within the rear cabin due to the intense heat and choking black smoke.
People were panicking straight away, but it wasn't so bad at the front. It was, well, I was in the middle because flames came into the cabin. the sides of the cabin. I don't know whether it's split or whatever, but there's flame. You just look back, you see flames coming into the cabin and smoke just coming right the way along.
So you were sitting at the front, so you got out quite easily?
Not quite easily, because we were in row 6, but it's 6 and it's 6 rows, there's 30 people in front of us, and everybody's trying to get into the aisle, and it's just people pushing and shoving.
Was it dark?
Oh, no, lights were still on, everything. Don't know how long that lasted for, because we were one of the first ones off.
And there was thick smoke at the time?
Just as we were in the queue to go down the chutes, it just come straight over our heads, but it was red hot, burnt back of your throat, it was like acid.
The stewardesses at the rear of the plane were faced with an impossible situation in the rapidly deteriorating circumstances. Both stewardesses and many passengers lost their lives in this section of the aircraft. The fire spread from the aft section of the cabin forward as roof panels and overhead lockers ignited and collapsed onto seats. Several areas of intense damage were possibly caused by flammable materials, including alcohol and aerosol sprays stored within hand luggage. At the front, the purser attempted to open the right forward door, which he found to be partially jammed. He then went to open the left forward door to allow evacuation. This was opened 25 seconds after the aircraft had stopped. Another 20 seconds passed before the right overwing exit was opened by adjacent passengers, and a further 25 seconds later, the purser successfully managed to free the jammed right forward door. The forward stewardesses had to pull passengers free, who had surged forward, becoming wedged in the aisle adjacent to the galley. A number of survivors owed their lives to the direct actions of the cabin crew, who remained on board until they themselves were almost overcome by smoke.
And someone got the doors open, it was just a big rush to get out. But we looked back and we could see flames come into the cabin and smoke coming along the roof. As soon as the smoke hit you, it was like a brick wall.
The speed of response from the Manchester Airport Fire Service had been rapid, and firefighting commenced approximately 25 seconds after the aircraft had stopped. The external fire was quickly brought under control, but by now the internal fire was well established. Additional fire appliances from Greater Manchester Fire Service quickly arrived at the scene.
When your men actually got to the scene, what confronted them?
About 2/3 of the aircraft was well aligned. That's the rear 2/3 of the aircraft was well aligned. A lot of people had escaped from the aircraft and there were still people aboard.
How long did it take before the fire was contained?
Well, almost immediately. When the fire service from the airport responded, they have special equipment and very quickly brought the fire under control.
Was the fire being fanned by the fuel tanks at the back of that plane?
Well, it's difficult to tell at that stage of the fire. You don't try to examine the whys and wherefores. You get on with putting the fire out and getting the people out of the aircraft.
The police coordinated and ensured protection of the scene and controlled the rendezvous points for all other services. Police headquarters were responsible for many areas of activity, including establishing a casualty bureau, collating information, and liaising with the press, radio, and TV. Ambulance services responded quickly and alerted the nearest casualty receiving hospitals. The injured and those overcome by shock and toxic fumes were immediately taken for treatment. Of the 131 passengers and 6 crew, 54 died on the aircraft. A further male passenger, who was found unconscious in the forward aisle some 33 minutes after the aircraft had stopped, died several days later. Of those who survived, 18 escaped from the front left exit. 27 used the right overwing exit. And 35 escaped from the forward right door, which had been freed by the purser. Only 40% of the passengers engulfed in the dense smoke survived. Of these, 8 collapsed during their evacuation due to toxic gas and smoke inhalation. 2 were dragged out of the front left exit by cabin crew, and a 14-year-old boy was pulled out of the right overwing exit by a fireman 5.5 minutes after the aircraft stopped. The commander and co-pilot had made their evacuation through the flight deck right sliding window. After investigation of the facts and circumstances surrounding the Manchester tragedy, Britain's Department of Transport's Air Investigations Branch made 31 safety recommendations. Since that time, safety actions taken by the CAA include the revision of inspection and repair procedures, the strengthening of fuel access panels, and on board, fire emergency equipment has been increased. Breathing apparatus for cabin crew is now required, and smoke detectors in toilets are fitted. The standards for cabin fire extinguishers have been improved, and floor-level escape lighting introduced. Flammability standards for seat cushions and wall and ceiling panels are now much higher. And in the cargo hold, there are now improved fire containment standards. Amongst ongoing research and development, the CAA have issued specifications for passenger smoke hoods and full-scale tests into cabin water spray systems. Research is being carried out into the use of closed-circuit TV to aid the crew's view of the aircraft exterior. And there are recommendations for improved evacuation procedures, an area highlighted by the Manchester disaster. Airlines have now been instructed not to allocate seats adjacent to exits to the elderly, the infirm, or children. Cabin public address systems have been improved, and new procedures brought in as to the positioning of aircraft on the ground in the event of fire. Methods have been revised for both cabin crew and fire brigades when fighting fires in cabins. Finally, the CAA have improved training techniques in all areas of fire safety for cabin crews. Research and tests are constantly carried out by leading aviation authorities throughout the world. Many lessons from the Manchester tragedy have been learnt, but the learning process must go on. And let us all hope that the standards of aviation fire safety will continue to improve because of it.
Did you read in the paper today? And a former Miss America denied Clinton. And that makes a...
On May 2nd, 1970, ALM Flight 980 ended its flight in the stormy waters of the Caribbean, approximately 30 miles east of St. Croix. This was the first commercial jetliner to be ditched at sea. Flight 980 had begun what was to be its last flight almost 5 hours earlier at Kennedy International Airport, New York. The DC-9's destination was the tiny island of St. Martin, the Netherlands Antilles. Cabin services were provided by flight attendants from ALM, Antillean Airways. The airplane and cockpit crew were furnished by Overseas National Airways under a lease agreement between the American and the Dutch carrier. The DC-9 carried 5 25-person life rafts, 2 stored on each side of the cabin in the ceiling above the overwing exits, and 1 in the coatroom closet opposite the forward galley. The boarding and service doors were equipped with inflatable escape slides. Life vests were stowed under each of the 105 passenger seats and at each cabin and cockpit crew seat. Passenger seat cushions could also be used as personal flotation equipment. With the DC-9 being flown at the limits of its range on this particular route, careful flight planning was a necessity. Takeoff delays and/or bad weather would require a refueling stop at Bermuda. ALM 980's cockpit crew took all this into account when they planned the flight from New York to St. Martin. 57 passengers, including 2 children, elderly, and some business passengers, along with a few residents of St. Martin, boarded the flight at Kennedy Airport. As the ONA captain, assisted by the first officer and navigator, piloted the DC-9 south away from New York, the ALM cabin attendants, consisting of a purser, steward, and a stewardess, tended to the passenger needs in the cabin. With 28,000 pounds of fuel on board, the DC-9's planned en route fuel burn-off was to be 21,000 pounds, based on a 0.78 Mach cruise speed during the first half of the route, and long-range cruise speed for the last half, with both halves flown at 29,000 feet. The company requirement of 7,000 pounds of fuel on arrival at St. Martin could have been met if the plane had been flown as planned. Unfortunately, headwinds and turbulence would cause the crew to deviate from the original plan before reaching the halfway point in the flight. Passing over Guava intersection at 1424, the flight still had 8,600 pounds of fuel on board. The crew estimated arrival at St. Martin at 1500 with 6,000 pounds of fuel in the tanks. A few minutes later, San Juan Air Traffic Control Center informed the flight that St. Martin weather was below landing minimums. Based on this advice, the captain diverted toward San Juan at 1445. Shortly after, the Juliana Tower at St. Martin advised Flight 980 that the weather had improved to an estimated ceiling of 1,000 broken, 5,000 overcast, and 4 to 5 miles visibility in rain. This report was later challenged at the safety board hearing by an eyewitness who was on the field at the time. He stated that there was a driving rain on the field and 0-0 conditions out over the sea where the DC-9 was flying. Based on the tower's weather report, Flight 980 changed course and headed for St. Martin once again. The DC-9 had been airborne for 3 hours and 37 minutes when the captain noted that 5,800 pounds of fuel remained, an estimated arrival at St. Martin at 1550 with 4,400 pounds of fuel. By the time the crew saw the runway on the first ADF approach through moderate rain showers at 1528, there wasn't enough time to align the plane for landing, and the attempt was abandoned. The unreported rain showers reduced visibility to the point where the crew of ALM 980 did not sight the runway soon enough to establish an effective approach. During the 11 minutes it took to fly 3 unsuccessful attempts, the DC-9 was flying at slow speed with the flaps and landing gear down with high power settings. At 1531, Flight 980 requested and was cleared to its alternate airport, St. Thomas, Virgin Islands. At 1533, San Juan ATC received the captain's request for a higher altitude because he was short of fuel. As the DC-9 climbed to 4,000 feet, the fuel totalizer indicated 850 pounds, an insufficient amount of fuel to reach any alternate field. To the unbelieving eyes of the crew, the totalizer then began erratic indications, pausing at 850 pounds, then 1,350, on up to 1,850, and then back down again. The navigator, using the middle figure of 1,350 pounds, computed that they could reach St. Croix with a few minutes to spare. At 1536, ALM 980 was cleared for St. Croix. At 7,000 feet, the totalizer stabilized at between 400 and 500 pounds. It was all too apparent now that a flameout was imminent. At 1539, the captain radioed San Juan Center. "There is a possibility that I might have to ditch this airplane. I am now descending to the water." Because the PA from the cockpit to the cabin was inoperative, the captain was unable to speak directly to the passengers. The purser was called forward to the cockpit, approximately 10 minutes prior to contact with the water. The captain advised him that they were low on fuel and to prepare the cabin for ditching. The purser understood this to be a precautionary measure and not imminent. But he made the cabin announcement immediately and assisted the steward and stewardess in helping individual passengers into life vests. Many of the life vests were difficult to remove from under the seats and also were difficult to remove from their thick plastic packages. None of the cabin crew realized the gravity of the situation and were not warned in advance of the actual ditching touchdown. The navigator assisted the steward in removing the closet-stored 25-person life raft and pre-positioned it near the galley door. As the DC-9 descended through 500 feet, the sea below it was turbulent, with churning waves 6 to 8 feet high, with swells seeming to come from all directions. The first officer went through ditching procedures from memory: seatbelt and no smoking signs. Emergency lights were switched on. The air conditioning was turned off, cabin depressurized, and battery power was switched on. The flaps were at 15 degrees and the airspeed about 145 to 150 knots when all the fuel pressure lights came on, then went off completely. Immediately, the captain went to full flaps, and shortly after, the engines flamed out. Without power, a nose-up attitude of 6 degrees, ALM Flight 980 flew into the water at 90 knots. Back in the cabin, there was no warning prior to impact with the water. While looking for the static line inflation handle on the raft and a place to attach it, the navigator glanced out the galley door window and saw that they were near the surface of the water and about to hit. He and the purser sat down on the aft-facing jump seat and held onto their unfastened seat belts awaiting impact. The steward quickly sat down on the life raft, which was loose on the galley floor. Upon impact, the whole galley assembly broke loose. The stewardess was up in the aisle helping a couple of passengers with their life vests when the airplane hit the water. No brace signal had apparently been given. Some passengers didn't have seat belts on, while others did, but they failed to hold. One girl assumed the brace position on her own. She saw the male passenger who had been seated next to her thrown 3 rows forward. Some other passengers were seated in the protective position. Some were sitting upright, while still others were standing, donning life vests when impact occurred. Some passengers were thrown out of their seats in spite of having their seat belts fastened. One couple reported that they had unfastened their seat belts before impact in order to be able to evacuate faster. The first officer had used his shoulder harness and felt that it had kept him from head injuries during the crash. Both pilots reportedly used their seat belts and harnesses. However, the first officer had not donned his life vest. Why didn't the cockpit crew give the brace signal to the cabin when the ditching was only moments away? The captain testified that he had blinked the seatbelt and no smoking signs and rung the steward's call chime. Signals which were not recognized as brace signals by the cabin crew because of their different emergency training backgrounds. The impact seemed to be one long, forceful deceleration. There was a moment of severe vibration as the ship submerged before surfacing again. A passenger seated next to a right overwing exit opened it immediately after the airplane came to rest and exited. At least 22 other passengers went out through this exit. The purser and the passenger in 1D tried to open door 1 left. The top of the door was deformed, and the door could only be opened a few inches. By now, the navigator and the steward had opened the galley door. The purser and navigator then tried to drag the raft on the floor to the door. It could not be moved. It was stuck. After much difficulty, the first officer managed to squeeze through a splintered and jammed cockpit door to the cabin. He headed back to the galley to help clear the area of debris. As the waves washed into the cabin and out again, the navigator and purser worked desperately to push the life raft out through the galley door. The raft became wedged between galley debris. With the first officer's help, the navigator and purser began clearing debris away from the raft when, somehow, the raft began inflating, filling the tiny galley area and pinning the first officer's leg. Efforts to puncture the raft failed. The raft separated the surviving crew from the passengers. The navigator was able to exit through the galley door. The first officer testified later that when the raft inflated, It felt as though someone had put a clamp around his left foot. Next thing he knew, he was in the water and didn't know how he got out. The navigator found the first officer in the sea without a life vest on and swam along the right side of the fuselage looking for something for the first officer to hold on to. As he swam rearward, the navigator was brushed by a large object in the sea. His first thought was shark, but as his panic subsided, he noticed that it was the galley escape slide which had somehow come loose during the crash. It was difficult to get a good grip and leverage in order to inflate it. With the aid of a woman swimming nearby, the navigator pulled the package in one direction as the woman pulled the inflation handle in the other. Inflation of the escape slide provided a group flotation device for passengers. Survivors hung onto the sides and used neckties and belts to provide additional handholds. Some people were clinging to a tire that had broken out of the cargo pit, and this too was lashed to the makeshift raft to keep all survivors together. The first officer, without a life vest on, climbed on board the slide and assisted people in the water. Although the navigator reassured the passengers that they would be found and picked up, he had his own doubts and a deathly fear of sharks. His concerns actually had a basis in fact. Local residents knew the area as Shark Gulch, a favorite shark fishing spot off St. Croix. The group around the slide examined themselves for bleeding. Bloody survivors would be placed on top of the slide so as not to attract sharks. The captain left the cockpit through the left cockpit window and swam to the left wing. A passenger seat blocked the left forward window exit. A male passenger had opened the left aft window exit and then sat there in a classic negative panic state, mumbling something about his wife. The captain pulled him through the window and then returned to the forward window and got that open. Several more passengers escaped through these windows. None of the 5 25-person rafts on board the DC-9 was deployed for use. A Coast Guard amphibian aircraft dropped 2 rafts over the ditching area, but they fell downwind too far away to be reached. A civilian Skyvan airplane from St. Croix also dropped 2 rafts. The captain and the navigator each reached one of the rafts, but were unable to maneuver either one back to the main group of survivors. The DC-9 remained essentially intact after the ditching and floated for about 10 minutes before it sank. Coast Guard, Navy, and Marine helicopters began survivor recovery operations with helicopter slings about 1.5 hours after the ditching took place. Conditions at the time were 400 to 500 foot ceiling with 6 to 8 foot swells and visibility as low as 3/8 of a mile in rain. All passengers reportedly had life vests on as the Coast Guard cutter Point Whitehorn made an exhaustive search for survivors in life vests. None were found. Heavy rains and rough seas hampered survivor sightings. The Coast Guard AMBER program diverted 3 merchant vessels to assist. 36 of the 57 passengers were rescued, but one of these was declared dead on arrival at St. Croix. 5 crew members were rescued. The stewardess was missing and presumed dead, as were 21 passengers, including 2 children. 18 of the survivors sustained injuries. The safety board determined the probable cause of this accident was fuel exhaustion, which resulted from continued unsuccessful attempts to land at St. Martin until insufficient fuel remained to reach an alternate airport. A contributing factor was the reduced visibility in the approach zone because of rain showers, a condition not reported to the flight. The board also finds that the probability of survival would have been increased substantially if there had been better crew coordination prior to and during the ditching. best circumstances, good weather, adequate water and food, skill in using survival equipment, and knowledge that search and rescue operations are underway are meaningless if you don't cling tenaciously to your personal will to survive. Survival means keeping your head.
Hello, Gordy. Hello, Gordy. Gordy, I saw where you went down. I'm coming over. Hold on.
Since there are few hard, fast rules for survival, each situation requires careful analysis. That is, weighing the possibilities and embarking on the best course of action. Besides having to cope with the shock of ejection and ditching, you have to know how to recognize and treat breathing difficulties, open wounds, cuts, bruises, fractures, injuries of any kind. Time is of the essence, but be as thorough as possible. Don't overlook a problem that could be life-threatening if it went unattended.
Come on, Gordy. Don't leave me, buddy. Don't leave me. Hang on, Gordy. Don't leave me. Much as the spirit of the departed has entered into the life immortal, we therefore commit his body to its resting place. But his spirit we commend to God, remembering how Jesus said upon the cross, Father, into thy hands I commend my spirit.
Feelings of despair are among the most severe survival stresses and can easily lead you into lethargy and withdrawal. How would you snap yourself out of it? Cold, rough seas present a terrifying survival situation. Again, keep your head. Recognize your immediate concern, your safety, and that of each of your fellow crew members. By working as a team, your tasks can be accomplished easier and more quickly. Due to wind and current, the raft may move faster than a person can swim. You can slow the raft's downwind progress by adjusting the sea anchor. Utilize life rings or any available equipment to aid in recovering all personnel. Carefully check for injuries. If you've not already done so, put on your anti-exposure suits. Salvage any floating usable gear. Inventory and check your equipment and supplies. Know exactly where everything is stowed. Now it's time to rig the canopy against the weather.
On cold oceans, you must stay as dry as possible and try to keep warm. Extra materials can be used as floor insulation and as covers. Take advantage of body heat by huddling close together. Cold exposure can be combated by taking extra rations if water's available, and through mild yet regular exercise. In sub-zero or high wind chill situations, hypothermia and frostbite become serious hazards. Hypothermia is caused by prolonged exposure to cold or to total body immersion in icy water. That can lower the overall body temperature, slowing the vital functions of the body. Rewarming is necessary to prevent acute hypothermia and cardiopulmonary arrest. Direct skin-to-skin contact may be the only available method to save the life. The human body naturally protects the vital organs by decreasing blood flow to the extremities and skin. The toes, fingers, face, and ears are extremely susceptible to frostbite, which may be initially detected by pain, followed by numbness. Visually, frostbite can generally be seen as a grayish or waxy yellow-white spot. Never exercise or rub frozen tissue. This may increase tissue damage. Prevention is the best remedy. Use the buddy system to watch each other for frozen spots. Use warm hands or the groin, armpits, or belly to warm up suspect tissue. Extra rations, shared body heat, carefully watching each other, clothing and protective headgear or pieces of material, and mild exercise can help to prevent serious cold injury. Immersion or trench foot symptoms can appear within a short period of time. It's caused by exposure to cold, prolonged immersion in water, cramped quarters, and restricted circulation. You'll notice tingling, numbness, and swelling. Gray, wrinkly areas with blisters or red blotches eventually appear. Keep your feet warm and dry using dry socks if available. Maintain circulation by exercising toes and feet. Then wear your shoes loosely. It's a good idea to elevate your feet and legs for half-hour periods several times a day. Beside cold exposure, seasickness can render you immobile and nauseated. It can increase your fluid loss and prevent sufficient food intake to generate needed heat. Use anti-motion sickness pills, if available in your personal survival kit. Try to keep your morale up with a regular routine. Set up watches to look and listen for ships and aircraft. Drill and practice using the signaling equipment and devices. And by all means, keep yourself and the raft clean of wastes and trash. Remember, anything you indiscriminately dump overboard could be reusable or attract sharks. Cold, rough seas will try to wear you down. Hang in there till the weather breaks, so rescue can get in and get you out. Tropical environments pose another set of problems. Protection against the sun and securing drinking water are the most immediate concerns. Care should be taken to protect every part of the body from sunburn and windburn. Cover the head and face as well as the rest of the body. Protection from dehydration starts from the very first moment of the survival experience. Dehydration is caused by the survivor not having enough drinking water to replace the water or liquids in the body that have been lost by seasickness and normal body functions: perspiration, respiration, urination, defecation, and eating food without water. A good rule is no water, no food. The only way it can be replaced is by drinking rainwater, canned water, or salt water properly processed with a desalter kit or solar still. The best way to reduce the water requirement is to lie down, rest, and relax. Cut out any unnecessary movement, just enough to keep circulation going with a little exercise once in a while. Fluid loss can be further retarded by dampening the clothing and breathing through a moistened cloth. This decreases the amount of water needed and minimizes the dehydration process. It's a normal function of the body to discard its poisons through urination. However, when drinking water is not available, it also is normal for urination to become difficult. It becomes painful. The fluid is thick and discolored. It can be discarded in small amounts only. It can also contain flecks of blood, which will alarm most survivors into thinking they're dying from internal injuries. They're not. This is normal. Lack of bowel movement, too, is common on rafts due to the shortage of water. Don't be disturbed about it, and don't take laxatives even if available. Laxatives will increase water loss. Exercise a little if you possibly can. This may help. At rest, in good health, with minimal food intake, the body requires at least 2 quarts of water per day. With sickness, injury, strenuous exercise, and in extreme environments, much larger quantities are required. Besides solar stills, other sources of water include catching rainwater and collecting morning dew. You may also encounter mental tricks, see mirages, experience vivid dreams, or hallucinate. Don't overreact. Realize your circumstances.
Helicopter, come and rescue us! Helicopter, come and rescue us! Bob, get up! Get up! It's a helicopter!
Heat exhaustion and heat stroke are serious threats. Heat stroke is a serious medical emergency that must be treated immediately.
Let's get him over the boarding ramp.
Pour water over him and fan to promote the evaporative cooling effect. The lack of the very necessities, water and food, can quickly lead to psychological problems, to delirium, and eventually death. It's your choice to be a victim or a survivor. The possibilities of chemical, biological, and radioactive warfare intensify the basic problems of survival. The threats of CBR warfare may include odorless, colorless nerve agents, deadly microorganisms, and invisible penetrating radiation from fallout. To combat these, it's essential that you carefully decontaminate yourself, your equipment, and food and water containers. Time and distance are in your favor. The longer you survive, the more dispersed these agents will become. Seawater should be used to scrub down your protective clothing, equipment, and supplies. Any surface that could become a resting place for CBR agents should be regularly decontaminated. And if you're down in unfriendly waters, you must avoid detection. Here, camouflage and radio discipline become essential. Injuries such as burns require special attention to promote healing and reduce the chances of infection. Don't touch the burned area. Cut or move away charred clothing from around the burn area and cover with clean, dry bandages. Burn injuries bring about pain, shock, infection, and loss of considerable body fluids and salt. Provide plenty of water in the early period before nausea and vomiting develop, and treat for shock. Cuts and abrasions should be treated with antiseptic and bandaged. Even small cuts should be kept clean. Treat all sprains, dislocations, and breaks in the same way. Immobilize above and below. After hours of exposure, you may have to face the problem of saltwater sores. They usually develop from a scratch or cut aggravated by saltwater and chafing. Do not open or squeeze them. Flush with fresh water, pat dry, then use the proper ointment. Keep the sores as dry as possible and well exposed to the air. Be prepared to set up for long-term survival, both physically and psychologically.
Look, you guys, we haven't got it so bad. We got plenty of water available. Fishing's not too bad. The wine's recovering nicely. We're drifting towards land.
Be resolved and stubborn in your commitment to stick it out.
Okay, you guys, let's give it our best shot. Let's do some fishing.
Hunger can present a serious discomfort to the survivor, though a man with plenty of water can live without food for many days. Food intake should be directly related to the amount of water available. At sea, fish is the most common food. Some fish are actually poisonous to man and are generally caught in shallow waters, 150 feet or less, especially around coral reefs. The safest fish to eat come from open sea or deep water. The silvery kind are good, with scales you can flick off with your thumb. Never try to eat or keep fish more than 2 hours after they've been caught. Seabirds and even seaweed can be other sources of food. But watch out for the first signs of nausea or stomach pains from unfamiliar food. Regurgitate it immediately. Organize your activities. Use your skill, your training, and your common sense to guide your actions. Kick in the survival mode and use personal motivation, thoughts of duty, mission, family, to help resolve psychological aberrations.
Oh, I know a fighter jockey went down. He was out there for 10 days. His buddy died in his arms, but he never gave up. I don't see any reason why we should.
Maybe we don't have it that bad. At least we're still alive.
Anyone who flies can expect the unexpected at any time, but that's not enough. You've got to anticipate and be prepared for it. if you keep your wits and if you've got the will to survive. Give us a chance to find you alive. After all, it's your life. Save it.
As you well know, the Middle East was a very unstable place, and in 1985, there was a hijacking about a week or 10 days prior to 847 hijacking, and I was flying the same flight, Athens, Rome, Cairo, and yes, it did enter my mind that I'm now in a part of the world where that could very well happen. So, very ironically, the day of our departure out of Athens on June 14th, it just occurred to me that we are in Athens, and the hijacking also occurred out of Athens the week before. And so I asked the flight attendants to please check the aircraft thoroughly, and I did the forward part, and some of my colleagues went to the back, and we did check out the aircraft thoroughly, because I did say, you know, ladies, remember there was a hijacking just last week, and we also knew that State Department people had been over in Athens checking the situation, security out. So I was more or less mentally prepared, as much as you can be, I think, to do everything right that we're supposed to do. We had a very short flight plan from Athens to Rome with a full load. You know, we flight attendants are kept pretty busy. After we took off, I mentioned to Hazel that I will not make the seatbelt sign off announcement, trying to keep everybody in their seats. That would give us a head start to set up everything. And I was putting on my smock and looking for a corkscrew when I heard a commotion in the aft part of the aircraft. Didn't pay much attention to it at that point. The noise got louder. I heard exchange of voices. I knew that some people were assigned in the smoking area that were non-smokers, and I thought, well, somebody's awfully unhappy back there, and disregarded it for a moment, and the noise got louder and louder, and I heard the Arabic language. I picked up some words. I knew right away. I said, oh my God, we have hijackers on board. As I upright myself to face them, I saw them rushing forward. I was picked up by one of them and thrown against the cockpit door, kicked violently at that point, cussed at, called an SOB American, and when he did that, my Arabic is not very good, but it's there, and I said to him in Arabic, I said, who are you? Where are you from? I said, I'm from Germany. I said, what is it you want? When he heard I'm from Germany, he turned to me with a gun to my head and said, you speak German? In German. And I am very surprised now. I said, my God, who am I dealing with? He speaks German. So my German being a lot better than my Arabic, we switched to German and our communication began. And it turned out that a third hijacker, who we are told speaks English, did not make it on the flight, Jim, because the airplane was oversold. So here they found themselves, two hijackers, taken over a fully loaded aircraft and with no way to communicate. This is, I think, the reason why they sort of took me as a communicator. There was no cockpit key. I still delayed the entry. The flight attendants in the back at that time rang the cockpit, trying to alarm them that somebody is on the way up. But the pounding on the door was so loud and so strong that the engineer looked through the hole, saw the gun in the hand, and told the captain, "We have a hijacking on our hands." Jim, they knocked at the door so violently that the panel on the bottom of the cockpit door that is made to come loose in an emergency, when you do kick it, it flew out. And I still did not open the cockpit door, and couldn't, because I didn't have the key, and the cockpit door was not open from the inside yet. They were trying to scramble in the cockpit to get ready to signal a hijack, and that they took that piece and tried to knock off the handle of the cockpit door, and they were somewhat successful. But during that process, the cockpit door was opened, and one of the two hijackers that had the two grenades with the pins pulled, the pins were in his mouth, and they were knocked out of his mouth. That's how close the door came to even knocking the grenades out of his hand, I guess. It was at that time that entered my mind, how lucky we were that one of the grenades wasn't lost during that shuffle. He asked me to pick up the pins and put them right back in his mouth, and I did that. And we entered they shoved me into the cockpit, and this unbelievable screaming began. And the cockpit turned around, and they were beaten at that point also violently with the fist and the grenades, and the man with a pistol whipped the engineer pretty bad. They were told they cannot turn around, they cannot communicate among each other. They were not allowed to use any flight maps, any route maps, and that the destination is Algiers. We heard him scream Algiers all the time. John kept saying, "No, we cannot make it to Algiers," and he said, "Yes, yes, yes," and his English was very limited, so he told me, he says, "You explain to them that they have come to die, that if they do not fly us to Algiers, this airplane will blow up." They told us at that moment there are 3 more hijackers on board the aircraft, that we don't know where they're seated. If we tried anything, that we would all die. At that particular point, John tried to convince them that the aircraft does not have the reach to fly to Algiers. Could they agree on another destination? And John finally said to me, "Now, Uli, you must explain to them, you know, in no uncertain words, that we cannot make it to Algiers." So I explained that to him, and I convinced him. He said, "Is it true?" I said, "Yes." I said, "Please believe me." I said, we will not make it to Algiers." And he said, "Well, that doesn't matter." He said, "We come to die anyway, so we crash." And I really begged them. I said, "Please, let's agree on a mutual destination and talk about it there." So the cockpit was able to convince them to fly to Beirut. Then, when we agreed on Beirut, he demanded a very steep left turn from the captain. He knew he had to turn around, and the airplane was still climbing out. We were very heavy. The airplane was not capable safely to make a steeper turn. The captain said, "No, no way, not my ship, you know." And he beat up John pretty badly in the back of his head, and John flew the aircraft just the way it was supposed to. And I said, "Look, we're turning around," and we convinced them. We told them to look down, that the water was to our left at that point, and we finally convinced him that the airplane cannot fly in a different angle safely. And the two were, the first 15 minutes in that cockpit, Jim, were very volatile. They were just in a rage. They had perspiration on their forehead. They were screaming on top of their lungs, clutching those pulled grenades. Once they agreed to fly to Beirut, one of the two hijackers stayed in the cockpit, controlled the cockpit, made sure they were not talking, using any maps or any radio communication. The other one went out with me into the cabin and asked all the first-class passengers to move to coach. So that meant, of course, they had to double up in the seats because there was no seat available in coach, and this was done in a very controlled fashion. They were extremely well trained to crowd control, to control crowds. They asked Hazel to go to the back, not to run, but to move. Everybody had to put their hands over their heads and very quickly find a seat. After they had emptied first class, they had ordered all the window shades down, and everybody had to go under the seat. Back, their heads had to be below the seat, back of the seat in front of them. And this was pretty much the position of the passengers for the first, well, all the way down to Beirut, and that flight lasted about an hour and a half. During that flight to Beirut, they established themselves on board through brutality, through terrible violence, demoralizing us. One moment being quite civil, the next moment without any provocation. They would hit people, they would kick them, they would do anything to tell them who is the boss at this point on the airplane. They did not tell us who they were, they did not tell us their demands. We had no idea who these two men were. All we knew was that they were Arabic speaking and that they were very young. He tried to tell me in the cockpit who they were. Had I heard of, and I'm sure at this point he said Hezbollah, but I had never heard of Hezbollah or paid any attention to them before at that point, so I did not register at that point. I tried to manipulate them a little bit. I told them that I'm a mother because they were very young. And just to give you an example, one of the two hijackers developed a sore throat because of all the screaming and talking, and so he would not have taken anything prior to that moment from me at all. I said, look, I'll mix you something. I said, hot water and salt, and you gargle that. I said, it helps. I do this for my son. And he almost, like a little boy, said, really? And I said, yes. And I had him, and he did everything I told him to. So I realized if I only search long and hard, maybe I can find whatever good there is that rests in him to talk him into letting us free. And I succeeded somewhat. At first he told me he would let me go regardless of what he would do with the airplane and the rest of the passengers. He sort of developed not a liking, but if the captain would have asked something, they would say no, definitely no. And when I tried a second time, they sort of were open to the suggestion. So I think normally in Arab culture, the woman is not the most important business partner, but maybe it was to our advantage that I was a woman on board in uniform who could speak their language, who was a mother. And they respect mothers highly because she is the center of the family. And that helped, very much so. Also, my knowledge of the Arab culture. I spent 2 years in Saudi Arabia, where as I mentioned earlier, where I went to school to learn Arabic. I was also very familiar with their culture. I knew that religion is central in their everyday life. The Quran is really their book of law. I tried to do everything right and not to offend them. I would not touch them as a non-Muslim woman. I wouldn't show them the bottom of my shoe, like crossing our legs. It's very, very, that's just not done. And they respected that. It was the first day of Ramadan, And I knew that, and he was very surprised that I did know that. He was very pleased that I knew that they should not be eating, but he did ask for food later on, and I reminded him again about Ramadan. And he said, but if you're more than 20 kilometers away from home, you are allowed to eat. And I said, oh yeah, that's right. So he did eat. And those were all little things that established mutual respect. I had them at one point give me the weapon. I convinced him that I'd like to look at this beautiful gun he had, and he did. So there you go. It just sometimes it's yours for the asking. It's strange. It's a strange thing. Our training prepared me for many situations on the airplane, and they happen almost identical to what they tell us might happen. For instance, they told us, there's more than just 2 hijackers, and we are always told, look out for more people, and they might just tell you they're over there. What did not prepare me was that the brutality. I thought once they were convinced that we were going to where they wanted to go, that as far as we were concerned, we were meeting their demands, that they would leave us alone. That was not the case. They would brutally beat people for no apparent reason. They blindfolded them, they kicked them, they jumped on their backs. They beat 2 people unconscious on the aircraft. I was not prepared for that. No training prepared me for that, because I always thought once they had established themselves as the leader of the aircraft, that would subside. It never did. Only during the moments when we talked were they civil. During the other moments, they were very, very savage. It's something I cannot explain to you, the brutality. And that was very difficult to accept.
Accidents and incidents that occur in the commercial aviation industry have a worldwide impact. Air travel, which is a primary mode of transportation, provides the fastest and safest way to travel. It's our goal as flight attendants, through safety training and updated aircraft evacuation skills, to increase the survivability factors in accident or incident whenever possible. In several emergency situations, you, the flight attendants, made the difference in safe and successful evacuations. On July 19, 1989, a United DC-10 en route from Denver to Chicago lost all 3 of its hydraulic systems. The flight crew prepared for an emergency landing in Sioux City, Iowa. United Flight 232 impacted seconds before landing. Amazingly, 185 people survived. What you're about to hear is Senior Flight Attendant Jan Brown's actual account of United 232.
When the phone chime went off, I knew that we had an emergency, obviously. And I went up to the cockpit and tried to look as casual as possible, because from the time of the explosion, passengers were watching us very carefully, because I think the feeling is if we look worried, they should be worried. And I've always felt if we look calm, it maintains comm with passengers, that he told me that we had lost all hydraulics to secure the cabin and prepare for evacuation. And we went into our short 10-minute or less version, step by step. I had their undivided attention at that point. You could have heard a pin drop. There seemed to just be calm amongst the passengers. I briefed my help by 3 helpers. I had a passenger facing my jump seat at 9A, B, and C, and I went through explaining the door to them, emphasizing that they were only there as backups for me, having helpers at the bottom of the slide. And then Captain Haynes gave us the signals to brace, and we started, all flight attendants all started shouting, brace, brace. Passengers all went into their brace positions. After a few seconds, 2 heads popped up, and my partner, who was opposite me at 2 right, and I both emphasized to get your heads down. They went down when we impacted, and then this horrendous noise of metal and everything started. And within a matter of seconds, we stopped, and I was trying to work my release on my seatbelt harness when I heard a male voice say, "Can I help you?" And I said, "I can't get my release." He came over and released my seatbelt, and I fell on him and jumped up immediately and started yelling, "Get out, get out." So I walked out into the cornfield and could not see over the corn to find a place to gather people. So I pushed as far away from the airplane and then looked around to find a place. I can't emphasize how flexible you do have to be. And yet you go in. The training came back of get the people out, gather them away from the airplane. That was all there. It was all automatic.
First, the crash of United Flight 232. At this hour, rescue workers and investigators are still searching an Iowa cornfield for additional victims and evidence as to precisely what caused that DC-10 to lose its hydraulic system and crash while making an emergency landing in Sioux City. The Iowa governor's office says there are 178 confirmed survivors. Another 115 passengers are believed to have died. The search for additional victims resumed at daybreak this morning. NBC News correspondent Bob Hager is at the crash site this morning, and he has a report. Bob?
Good morning, John. Well, the general belief here is that this scenario began with a failure of the engine up over the tail, although it could have been another engine and some debris coming off into that engine. That engine over the tail then spewed out debris, maybe even had lost a piece of the tail, that the spewed debris broke the hydraulic lines that in essence control all the surfaces of the aircraft, the wing flaps, everything else. You need hydraulics to put flaps down. You need them to turn. So this pilot was trying to bring the plane down without much control of it at all, and he did a remarkable job. He came down in some big 360-degree circles, 3 of them. He almost made it. He got it down, leveled off at 200 feet. He was coming into the runway. At the last moment, the wing dipped down. He didn't have any control over it, and it touched the ground and flipped.
Piedmont Flight 1489, en route from Washington, D.C. to Charlotte, North Carolina, developed a malfunction with the left landing gear. The aircraft diverted to Greensboro, North Carolina, where several maneuvers were attempted to release the gear. When the tower confirmed that the gear was still up, the captain informed the flight attendants to prepare for an emergency landing and evacuation. The flight attendant crew assigned buddies, demonstrated bracing positions, briefed able-bodied persons, and prepared the cabin. The bracing signal was given by the captain, and the flight attendants shouted commands as the 737 approached and landed in Greensboro. When the aircraft came to a complete stop, the crew safely evacuated 100 passengers in 63 seconds. No injuries were reported.
A close call today for Donald Trump's new airline, the Trump Shuttle, that happened on a flight from New York to Boston. The Boeing 727 landed without its front landing gear, which jammed. The pilot gently brought his nose down to the runway. Passengers have been told to put their heads down. The passengers then slid down emergency chutes. The jet was foamed down by rescue crews. None of the 56 people on board were injured.
Everyone followed our instructions to a T.
And when the impact came, we told them to brace, put their heads down. The plane came to a complete stop. We opened up our evacuation doors, the slides inflated, and they all went out.
An Eastern Airlines jet was forced to make an emergency landing today at Atlanta's Hartsfield International Airport. None of the 48 people on board was hurt. Flight 581 to Atlanta from Albany, New York, landed on its left wheel, nose gear, and wingtip, and slid to a stop. Its right landing gear did not go down. Airport firefighters coated the plane with foam. As soon as it stopped on the runway, passengers immediately disembarked safely through the rear of the plane.
He came on the PA and told us to prepare the cabin. We were going in with gear up. That's when we moved all the people to the back. I got on the PA and told them to go to the back. We were going to use the air stairs and to get back there. We probably had less than 5 minutes to do everything then. So we were coordinated enough to go quickly through our 9 steps other than the ABP briefing for the door. We got the people in the back, got them in a seat, showed them their seat belts, you know, showed them how to do their seat belts, told them low and tight, keep them low and tight. The other 3 flight attendants were in the back showing the brace and positions, and they took a little section of, you know, the 44 people, they took a little section each and showed them the brace and positions, and then the captain said, "We're going in, are you ready?" And we said yes, and he said, and I got on the PA and told him, bracing positions now.
After the airplane came to a complete stop, the passengers remained in their seats. Hannah got on the PA and told everybody to open their seat belts and exit through the back and don't take anything with them. At that point, we started calling, "Come this way, come this way."
The plane had come to a complete stop. I got out on my jump seat after I had actually unfastened my seatbelt. I checked for the aft door for any fire obstructions, for any heat. When I knew that was okay, then I opened the door, latched it, then rechecked to see if there was any fire obstruction at the bottom of the stairs. Then if I knew that was okay, then I opened the compartment door, opened and then grasped the handle, pulled it outboard. The stairs went down in normal operation, and once the stairs were down, I followed, went down the bottom of the stairs, and I stand at the one side of the stairs, and I yelled out, "Come this way, come this way."
The incidents you've just seen were planned emergencies. The flight attendants had time to prepare their course of action. However, an unplanned emergency requires flight attendants to use their training and judgment to act instantly, without the luxury of time to prepare.
In New York, the investigation continues into the circumstances surrounding this week's crash of U.S. Air Flight 5050. The plane skidded into the East River after its pilot aborted its takeoff from LaGuardia Airport.
But as the jet moved down the runway, a different and more crucial problem developed. The plane began to drift.
The captain said he felt and heard a vibration which concerned him, and he attempted to correct the drift, but it continued, to the extent that the aircraft drifted halfway between the center line and the runway edge. Because they were still moving to the left, the captain said that he initiated the abort.
The brakes and reverse thrust were applied, and the 737 went into a long skid that carried it over the edge of the runway and into the East River.
The aircraft broke into 3 pieces. Flight attendants evacuated passengers through doors and window exits. The entire flight crew worked together to ensure the safety and calmness of the passengers until the rescue workers arrived.
Today, from the crash of a Delta Airlines 727 in Dallas a year ago, a federal judge released the cockpit tapes of Flight 1141. BC's Robert Hager reports tonight the crew's conversations proved to be both shocking and prophetic.
The public release after this crash of audio of the private cockpit conversation is unprecedented. Normally, only transcripts are available. The tape includes this joking before takeoff.
We forgot something on our first leg today. We forgot to discuss about the dating habits of our flight attendants so we could get it on the recorder, you know, in case we crashed and the media would have some kind of a juicy tidbit.
I think they have nothing on this.
We got to leave something for our wife and children to listen to.
Delta has confirmed that as the crew talked, they forgot to extend their wing flaps for takeoff. Here again the sound as the crew called VR for liftoff.
VR, V2, engine failure. We got an engine failure.
The FAA implemented the sterile cockpit regulation in 1983. Sterile cockpit means no interaction unless safety is involved below 10,000 feet during taxi, takeoff, and landing. It's also the flight attendant's responsibility to make sure sterile cockpit is maintained. Whether a planned or unplanned emergency exists, you, the flight attendant, make the difference. Evacuation and bracing commands should always be fresh in your mind. Your experience and training as safety professionals is crucial in any emergency situation.
Time now for a look back at tonight's top stories. A mid-air incident on board United Airlines Flight 811 after an apparent structural failure caused a gaping hole to open up in the aircraft. Tonight, 9 people are still missing, apparently swept from the airplane.
Those terrifying moments came about 20 minutes after the 747 took off from Honolulu Airport, headed to New Zealand. The flight originated in California. Suddenly, it is speculated, the right front baggage door blew out, the pressure causing the rest of the plane's skin and structure to give way. As many as 16 passengers were sucked out through the gaping hole. It is suspected that the fuselage debris flew into engines number 3 and 4, causing them to lose power.
In all, there were 354 people on board Flight 811. Most lived to tell about the tragedy because of the skill of its crew.
Hell let loose because all the debris was flying everywhere, and there was a really strong wind, and it was sucking everything through this huge hole.
The girls kept screaming out, hands forward, get ready for emergency landing, hang on to your ankles, wait until the plane stops.
The flight attendants had to quickly deal with a very difficult situation and prepare the aircraft for an emergency landing amidst hurricane winds and swirling debris. Flight attendant Sarah Shanahan was on board that flight. She received a heroism award by the Secretary of Transportation.
I was the aft purser on the aircraft. I was flying, we had a crew of 16, and there were only 4 of those people that I had ever even seen before we got on that plane. I mean, everything that isn't nailed down just goes sailing past you, and there's a fog that envelops the cabin because there's immediate condensation of the moisture inside the airplane. My immediate reaction was that I had to breathe. If I couldn't breathe, I wouldn't be able to get out there. Your training kicks in and you just know what you have to do.
The entire crew from United Flight 811 received heroism awards from the Secretary of Transportation for their performance and skill as safety professionals. Recent public interest in airline safety has proven that even the most minor aircraft incidents are newsworthy.
Another problem in the skies involving a jet's hydraulic system. This time it forced an emergency landing in Orlando.
An unscheduled stop in Orlando for a Continental A300 Airbus jet with a hydraulic system leak.
A problem in the hydraulic system forcing a Braniff 727 to turn around today.
The flight attendant provides safety information to the traveling customer before each flight by demonstrating the operation of emergency equipment and exit locations. A recent safety recommendation by the FAA is showing the passengers how to remove the life vest from its plastic package. Improvements on board all aircraft include exit path lighting directing passengers to the nearest exit, as well as seats covered with fire-retardant fabric, which delays the intensity of heat and the release of toxic fumes. These safety improvements have increased the survivability factor of airline accidents. To help combat the sophisticated terrorist weapons, the FAA is testing and implementing neutron scanners, which are capable of detecting plastic explosives. 1989 was an eventful year in the aviation industry. You, the flight attendant, are the professional trained to react. Accidents and incidents can happen anywhere, anytime. Remember, you make the difference.
Thank you.